Good afternoon. It is so impressive to present here. Thank you for the invitation. I must say this, wow. I wish I could photograph it. I'm going to tell you, well, Georg introduced me already. I was a general practitioner until at the age of 30, or I remained a general practitioner, but at the age of 30 I became ill myself. And I was fully surprised, it was quite serious, but I was fully surprised to be a patient. And of course I understood medically what I had, but being a patient was completely different, much more than that, so surprised. I recovered, went back to work, and then I got a second illness. And then a third, and then a fourth. And from the second one I decided to continue studying being a patient. Because with the first, and there were 4 different diseases, and the first disease I found I can do very much myself to recover, to feel better. And I wanted to know if with a different disease that was different or there were similar things I could do. Well, I call this was the most difficult period of 5 years of my life, 30 to 35, but the most learning, teaching, most experiencing period. And at 35 I decided I have the medical knowledge, but I have knowledge as a patient which I want to add to medicine. And if I want to change medicine, it needs to be science. So I decided to become a researcher. And I was a researcher for 30 years, and what I'm going to tell you is about my research. It's promised not too difficult. But it is the basis which convinces many doctors in general medicine and also others. And besides that, I worked, because I loved the work so much as a doctor, I worked with drug addicts and with people with war traumas, because I wanted to know how much is possible to heal people who are really, you can say, broken down. And I'm very convinced about what is possible. Well, I worked 30 years in silence, and then as a kind of therapy for some frustration, I did my PhD, and suddenly there was a paper, a story in the paper, and people said, this is what we want. Now it's now 7 years ago, and now it is really a movement which is spreading around the world. I'm going to tell you about that. Well, I say, what is health is the question, and then it's the new concept of health, more dynamic, and elaboration, working out on the individual and the social or community level. First of all, I quote the same as Georg did. We speak about health care, but in fact, it is disease care. And I was very impressed by this picture, which was once shown by a director of an insurance company, health insurance company. At his farewell, he showed this picture and he said, this is how the costs in healthcare are divided on the left-hand side. And it's an enormous amount of money everywhere, but the thing is that you see at the top, you see the mental health care, the hospital care and the long-term care. And the biggest amount of money is going there. To the general practitioners, you can say the integrated care, much less is spent, and all that money is blue. That means these are people who already are ill. And in Holland, we appreciate very much that everybody is free to live as he or she wants, and when you get ill, we treat you excellently. But it is, you see at the bottom, you see how much we spend on prevention. And nowadays we know that at least 50% of the chronic diseases, but probably much more, can be prevented by lifestyle. At the moment in Holland we spend 2% of this 100 billion euros that we spend on health, 2% goes to prevention. But the interesting thing was that this director said we're going to the right triangle. There's going to be a complete shift. And of course it's a tendency, not all the hospitals will disappear. But you see that the small pink triangle on the left will become the bottom and really will carry it. And of course, an insurance company has a financial motive, but he also thinks, he said, people will be much happier. And after my own illnesses, I got interested in this pink part. What is health really? What is resilience? What can you do yourself? And what I found out, and I worked 30 years in science in the Louis Bolk Institute, you need to really realize that adopt a complete new way of thinking. And that is represented in these two pictures. And it's about the question, how will the small green ball stay in place? And on the left-hand side, you see this curve where the ball is laying on top of it, and you can imagine that if these two arrows would not be there, the ball would fall off. And I must say, as a doctor, I was trained this way. We know an immense lot about details about illnesses, and with medication we really get targeted, we control the situation. We often do not really heal, but we keep the situation in control. With diabetes, with high blood pressure, etc. If you take the medication away, the disbalance will start. And we call that the control model. And that is a result of hundreds of years of analytical science where we are developed very much. The right-hand drawing is also science, but it's a new way of thinking. It's from ecological science. And this drawing comes from Wageningen University, where they also work on ecology. It's not their biggest part, but I like the drawing very much. You see this ball, and through the shape of the ball, this green ball remains in place. And you can shake it, but it kind of, how do you call it in English? I don't know, but it will go back and forth. I think this one I wanted. You can read all the things that are below it, but it's a different approach on the left-hand side and on the right-hand side. And I just quote what is on the bottom. On the left-hand side, you create a static equilibrium. It's kind of, and on the right-hand side, you create a dynamic equilibrium. And very typical about the right-hand side is that curve is formed by many different factors. And it's kind of you kind of steer on different factors to maintain this ball. And this right-hand way of thinking is the new thinking we need to restore ecology, to restore balances. And exactly on the right-hand side, the Louis Bolk Institute, where I worked for 30 years, works, and I embrace that from the medical point of view. Well, now some knowledge about what we already know about health and resilience. I give you 3 perspectives. And you probably know them, but it's good to realize it. All over the world, blue zones are known. Places where people really get old and really even over 100 years of age without chronic diseases and without mental illness. And we usually in Holland we say people get older, but sorry, you get your chronic diseases. That is not a necessity. And the nice thing about these blue zones is that they are diverse over the world. These people have different genes. It's not their genes, it's their lifestyle. And the 4 most influential factors, I will tell you, the first one is their nutrition. And of course, nutrition in Japan and the East is different from the Mediterranean and different from the Western United States. But all these people eat freshly prepared food. They eat mainly plant-based food, very little animal proteins, and they eat, you can say what science is 80%. They kind of eat moderate amounts, not till they're fully stuffed. That's one thing. Nutrition, fresh, vegetable, and moderate. The second thing is that they move, but not in sports schools and so. These people do not sit at old age on the couch for the television. No, they're active. They are active in a natural way, so movement is very important. And in the Netherlands, if they speak about health, they always say nutrition and movement. And they do not mention the third and the fourth factor. The third factor in all these areas, all these people have a life which they experience as meaningful. Until old age, they get out of bed because they like and are fulfilled by the things they do. And the fourth factor is that they all have the feeling they are part of a social community. And that can be a village community, that can be a big family, as you can imagine in Italy, or it can be a spiritual community, as in the Western United States. The latter two, the third and the fourth factor, are just as important, the meaningfulness and the social connectedness, and not being lonely, like you told already, Matthias, are just as important factors. So that we know. Okay, I go to a next knowledge we know. From Mr. Antonovsky. You may know his name is connected to salutogenesis, the opposite of pathogenesis. And Mr. Antonovsky worked in Israel, in Tel Aviv, in a hospital, as a medical sociologist. And he met many patients who had survived concentration camps. And of course, not many Jewish people survived, but the people who survived, many of them went to Israel. And many of the people he met there were traumatized. But among this group, there was a smaller part of people who had experienced the same thing and were not traumatized. And he wondered, what is the specialty, what characterizes the people who are not traumatized and survive the same horrible things? And he found three characteristics. Together, he called these the sense of coherence. And these characteristics were comprehensibility, manageability, and meaningfulness. And what does it mean? Comprehensibility means that you have some understanding of your situation. So it's not that you're completely confused, like is standing below that. Manageability means that you have at least the feeling that you can decide on a little part of your life. You're not fully a victim. Can you imagine in a concentration camp that you have the feeling that you can manage? Well, people explain that they still think their own thoughts. They decide what they think. So that feeling that you decide is very healthy. And the third factor that Antonovsky found was the experiencing of meaningfulness. Some meaning, however, so the opposite of meaninglessness. And according to Antonovsky, meaningfulness was the most important one of these three. Then I go to the third thing, and that's my own work, the definition of health. The WHO formulated, I think, a beautiful definition of health in 1948. Health is a state of complete physical, mental, and social well-being, and not merely the absence of disease or infirmity. And when I first heard it, I thought, this is beautiful. But when I had to work with it, I met some problems. You must realize it was formulated in 1948 after the Second World War. And one of the few good things of the Second World War was that the antibiotics became available. They were there, but they were taken into production for the army. And at that time, they knew the infectious diseases. And people thought, now we have the antibiotics and we're going to heal all the infectious diseases. And they could not imagine at that time that we would get a different kind of diseases. I've studied the minutes of the starting of the WHO for my PhD thesis, and I was very impressed by the idealism which is behind this. People who founded the WHO were very idealistic, and they had the idea, we're going to lead mankind to this situation. Wonderful. But if you say health is a state, so it's always there, and it's complete, physical, mental, social, who of you would say, yes, I'm that healthy? You understand, that was the idea, and if you call it a definition, you kind of demarcate it. You say, these people are healthy and those are not. And without realizing this, these people kind of contributed to medicalization. Because this is the goal we want to reach. So doctors have to treat to reach this. Well, I worked, after my own illnesses, I wanted to work on resilience. So recovering and getting over problems, etc. And that does not connect to this definition. And I was not the first one to criticize it, and there were many proposals, but I was in discussion with the Dutch government, and they asked me to work on it, because they said, we as government have a problem with this definition. It's holy, but we have to aim all our work and policies towards that. And because I addressed it, they asked me to organize a conference, invitational conference, with big shots from all over the world. And in 2009, we had a meeting with these beautiful, very wise people to discuss a possible alternative for this definition. And we discussed many, many, many aspects, because health is so broad, but this is what we decided on and what we published in 2011. Health as the ability to adapt and self-manage in the face of social, physical, and emotional challenges. So we have the same domains as the WHO, the physical, the mental, and the social, but not as a complete state of well-being. But on these fields, we are challenged all the time. You get in different situations which you are not acquainted to. Can you learn to adapt? Adaptations is meant as not I adapt, but can you learn to find a relationship to it? And we put in self-manage, that by that we mean that you do it in your own way. So you can say this is about resilience, ability to adapt, and the self-management is about this manageability of Antonovsky. You learn to find a relation in your own way. This is how we decided it. And if you like this article, you can read in the British Medical Journal. But then I got a follow-up question from the government. This publication is going around the world enormously. The WHO did not adapt their definition. Let me be clear about that. I don't know if I will experience that, but I was asked to do a follow-up study in the Netherlands, to do research on the support for this description and try to operationalize it, make it really practical, elaborate. And they asked me to study among patients, and I studied with focus groups on patients with many diseases, physical and mental diseases. I studied healthcare professionals, and those were doctors, specialists and general practitioners, physiotherapists and nurses. And of course you can say, why not dietitians and psychologists already? We had no idea what would come out. This was already much. I included policymakers, health insurances, the public health professionals, citizens, and I added myself, the researchers. And I did a qualitative study and a quantitative study. The qualitative study were interviews with individuals. I did 50 interviews with 140 people, individuals or focus groups. And these results we kind of checked in a quantitative study which came afterwards. And I'll shortly present what I found. I had to ask what is the support for this description. And I first asked the people what do you think is positive about it? And then I asked what is negative. And to my surprise, people were very positive about it. And people said, this is about the whole person and not the disease. And patients said, I feel addressed in my strengths and not in my weakness. I am not the diabetes, I'm a person with diabetes. And although I have an illness, a diagnosis, besides that, I have lots of healthiness. And it has a lot of potential. You can strengthen it. So there was a lot of support for this. When I asked what is negative, some people asked, how about disease? Do you treat disease still? Because it's not in the definition. And let me be clear, of course you treat disease if possible and necessary, but you see the whole person and also what is still healthy and what a person can do. A very serious question, a very respect question, is everybody capable of that? No, of course not, but you don't have to. You have to connect to where a person is and then help him step by step to enlarge and strengthen this. And the last question is, do you have attention for the social environment? Or does somebody have to manage himself? Because one of the objections was this description of yours is very neoliberal. You can say it's your own responsibility if you're healthy. And I said, no, if you see what we intend, it's not meant like that. But of course, you have to take these objections serious. The interesting thing was there was an advice, and several people said, don't take health as an aim in itself, don't make a health industry, but take health as a means to a meaningful life. And I thought that is interesting, because I knew already the importance of meaningfulness from the Blue Zones. I knew it from Antonovsky, and now it came also in my interviews, it came up. And I decided I will put this meaningfulness, the importance of that, into the elaboration. My second question was, because I had to operationalize it, asked, what do you look at if you want to evaluate health? What are indicators for you? And after my 50 interviews, I came home with 556 indicators. It was a broad bunch of words, and we categorized it. We did it with patients, we did it at our institute, we gave it to a different institute. And first we came to 11 dimensions and then to 9, but we condensed it all over to 6 dimensions of health with aspects below it. And these were the original names of the aspects: bodily functions, mental functions, and perception, which we separated from the spiritual and existential dimension, quality of life, social and societal participation, and daily functioning. But you will probably experience, you know that if you speak to general doctors about the spiritual or the spiritual existential dimension, they get a kind of allergic reaction. So we kind of changed it, we adapted it to a more accepted language. Bodily functions remained the same. We spoke about mental well-being. We speak now about meaningfulness, the quality of life, participation, and daily functioning. So those are the mixed 6 main dimensions with below it different aspects and words. Okay, these were the results of the interviews, and I put them into a questionnaire and went back to the stakeholder groups and evaluated these outcomes. And you see altogether we had 1938 responders. Nice groups, only the corporates, you can say the insurers were not, at that time, not very interested. That group is too small, but the rest was nice. In the questionnaire, these people supported our description. The positive results were really supported. Okay, that was nice. Also the negative ones a little bit. But then came these 6 dimensions and the aspects. And this came out. This is the only graph I will show. But what you see here, you see horizontal axis with 6 main dimensions in the original world. So the physical, the mental, the spiritual or meaningfulness, the quality of life, the social aspect, and the daily living, daily life functioning. On the vertical axis, you see numbers because we had a scale of 1 to 9. And everybody was asked to tell how much they found different words to be an indicator of health. How much does the ability to function, to function in a social way is part of health. And what you see is the different colored lines are the different groups we studied. And immediately you see on the left-hand side, all the colored lines are coming together. That is where we had the terms about the physical body, the bodily functions. Everybody agreed that that was part of health. And if you go then to the right-hand side, you see these lines divide very strongly. People had very different opinions whether these other 5 dimensions had something to do with health. And if you look to the extremes, at the top you see a green line which curves a little bit. That group distinguished the 6 dimensions as nearly as important part of health. They have a very broad opinion about health. That was the group of patients. 575 patients had that opinion about the 6 dimensions. On the other side, you see the purple line at the bottom. They are the policymakers. They have the highest score at the physical, and for the rest they do not come that high. And these are the people who made the regulations also for the patients. So then it becomes very interesting. And I had a problem because everybody supported our description, ability to adapt, but in the elaboration, the operationalization, people divided very much. I had to discriminate between this narrow interpretation, which more or less said the policymakers and the doctors said health is the more or less absence of disease. You look at the physical part. On the opposite, I had the patients who said health is about life as a whole. And I decided I had no scientific reason to choose, I had a social reason to choose, to follow the patient's opinion. Because in Holland, as in other countries, they say we place the patient central. The patient is central, and that's what we all say. So I had an argument to say, okay, wonderful, but you should know how the patient thinks. The patient says health is about life as a whole. So that is why I did follow this broad interpretation, and I needed a new name. I could have called it broad health, which would have been adequate, but I didn't like it so much. And on the one hand, our descriptions connect to positive psychology, but I was really convinced to choose for positive health when I studied these minutes of the WHO, and I found a discussion where the WHO has considered to use positive health. Finally, they decided not to do it, but I thought, if I choose this term, I'm kind of in line of the intentions of the WHO. I like it, and people like it very much. We write it with 2, how do you call it, big kapitel? I don't know. Because it's not new in literature. It's described with a different meaning. And R, we write it with a big P and a big H. And our term is connected with 6 dimensions. And we put it in a spider web. And across the axis of the spider web, there are numbers. In Holland, we have, in school, you go for scales from 1 to 10. Every Dutch person knows it, so it's a bit different in Germany, etc. But from the start, we had this drawing, which you see on the right bottom. People liked very much to give themselves a score about how they experience their functioning and well-being on these topics. And if a person fills out this spider web, we do not have norms. We do not say, then you give a 2, a 4, or a 6, but everybody has an own reference ID. When am I functioning well? When not? And that's very personal. And that is exactly what we aim at, that people start to reflect on themselves. So they fill out their self-reported health. And you connect it and you get a health service. And then something important is very important. So on the one hand, the broad interpretation of health, and then we ask the question, would you like to change something? And I'll explain you why we do that. And then we discussed what somebody could do. Why do we ask somebody if he wants to change something? Because we found out that if we say, as usually as professionals, we say what somebody has to do. But people do not so much what they have to do, they do much easier what they want to do and what is of value to them. We found, you know, probably Antoine de Saint-Exupéry, you know, the man who wrote The Little Prince. I found a wonderful quote which really represents what we are after. If you want to build a ship, do not ask the workers to gather wood. Do not give orders and instructions. Instead of that, learn people to dream of the endless sea. And then the ship will be built. This is exactly the second typical part of what we call positive health. We aim at what people really want and what they dream of. And if you see this spider web, this score, this is low, but I saw it with drug addicts, with people who are homeless, etc. You can see these scores. And as a professional, I asked you, does the dent draw your attention where it's the lowest? Usually, as professionals, we immediately look where the score is the lowest, and then we think there needs to be done something. And that is what we train professionals not to think, but to ask, what would you like to do? And I was really impressed. It was more or less I found out in practice that if I had such a score and I asked, what would you like to do? People might start to talk about their highest score and tell what they wanted to achieve there and even increase it. And if you aim at that, at somebody who wants themselves, you have this result. It's a bit short, it doesn't go that fast, but I want to show that if a person aims at what he or she wants, then the scores on all the other dimensions increase too. And people who are clever say, but this is well-being. Yes, of course, this is well-being. People perceive well-being. But I don't call it well-being because otherwise the doctors will immediately shift it to the social domain. We call it positive health, and we want the doctors also to work with it. And people who work with it find out that it works. This is what it looks like now. It's already the second version, where at the bottom you can also add your own word. We have it in Dutch, of course. We have it in English. It's in German. It's already in Spanish because we're very active in Colombia. It's in Japanese. It's in Icelandic. I don't have them all included, but I'm just surprised. And it's all published because we publish, of each step we try to make a scientific publication. In practice, working with positive health is about 3 elements. First is filling out the spider web, which is a kind of broad reflection. It is as if you look into the mirror, and it can be confronting, but people like it. This is my spider web. The second step is what we call the alternative conversation. Our trainings, we have short trainings where we train professionals but also citizens for the alternative conversation. That means that you start to listen. You ask what is important for you, what matters. Would you like to change something? And you listen. Now I can tell you, for professionals, keeping their mouth shut is the most difficult part to learn. It is known from research that general practitioners might, even after 11 seconds, interrupt, immediately take the lead. We teach them to remain silent, and that's very uncomfortable. But they find out that the other person doesn't mind because the other person starts to reflect and then starts to tell. And that works. And when the other person, you can say the patient, but it doesn't need to be a patient, says what is most important and what would you like to improve, then you ask, and how could you do that? What do you think of yourself? We're used as doctors to say, I know what you should do. No? Ask the person what you think of. And people come with, very often they know exactly what to do, and they come with suggestions where I as a professional had never thought of. But then you discuss, okay, how would you like to start doing that? And can you make it really small, that you really can do it? And can we meet each other again in 1 week or 2 weeks? And then we coach people to take the lead and take small steps in the direction that they want. So it's a different attitude than what we were trained were in the beginning. And it was not intended, but after a while I found out there's these three concepts of Antonovsky, the comprehensibility, manageability, and meaningfulness, are included in this way of working. Because filling out a spider web, I have heard people with a very low education say, look at their spider web and say, oh. At first it was confused, and now they see it kind of spread out. They see their situation, and it gives clarification. Then the question, what is important to you, behind that is their personal meaningfulness. You don't have to ask what is meaning in life. That's far too difficult. We just ask, what would you like? What would you want to do? And then you touch something which is connected to the personal meaningfulness. And then together look for what a person can do, him or herself, is this manageability. The person can take the lead and take the small steps. And we find out in practice that this works very well. It motivates people like it. And, well, I can later tell some results. I go just quickly practical. We worked it out. I started this Institute for Positive Health, like Georg told. We have brochures, very simple ones. We have now, besides the adult version, we have a children's version, the adolescent version. We have a version for people with language problems, which you can also listen to. We make each version with the group themselves in a scientific way, and we publish it, and we have these small blocks where you can take one piece of paper off. Our public health service made an app store based on the dimensions, because there are 300,000 health apps. But these professionals evaluate apps and for the understandability about the privacy respect. And so if a person doesn't know what to do, he can go to the app store and for free get suggestions. We wrote a book, like Georg said. This is the handbook for positive health in primary care. It's very broad, and you don't have to be a general practitioner. Also, it's also about the physiotherapists, about the nurses, etc. But we started somewhere. This is the English version. It's at the moment being translated in German, and it's intended to be translated in Spanish also. I'm very happy with that. And my colleague, Caroline van der Brekel, who you see the name at the bottom, started Positive Health International because there is so much need and questions from all over the world that she started this Institute for Positive Health International. We give, I say we or they, there we have many trainers, courses digitally in English, also very soon starting a course in German. I'm not going to read all this because I want to tell you some more. This is the development toward positive health. Then something happened in 2019. I was in Canada and I met my buddy from 2009 of the conference, Alec Jadat, or Jadat, you say in Spanish. He is from Colombia. He was for 20 years a professor in Canada. And before we had this conference in the Netherlands, he had published in the British Medical Journal a kind of request. We need a worldwide discussion about the definition of health. But only few people responded. And then we had read that, and we started to organize this conference in the Netherlands where we invited all these people from the world. And he was my buddy from the start. And he's a very active Colombian person. And I saw him back, well, you see me smile. This was really fun. But the interesting thing was I had been very busy in the Netherlands developing it. And at the same time, he had developed it also, this ability to adapt and self-manage in a different direction. What turned out that we had this health of the ability to adapt and self-manage in the face of social, physical, and emotional challenges. In the Netherlands, I developed it on the individual level into positive health. In Colombia and Canada, Alex Haddad developed it in the community level. He developed the concept of trusted networks. And I'll tell you a little bit with a few slides of his. And when I heard this, because we had not been in contact, just being too busy, I immediately saw this really connects. This is just beautiful. Because in the Netherlands, the meaningfulness is the central concept, the central idea. And in his approach on the social level, the community level, it's about trust. Well, we thought we should combine it, and we're at the moment working at that. And I'm going to tell you a few slides of what he experienced in Colombia. He's now from Canada back in Colombia, and he met their big problems. They had this civil war, of course, and he was contacted by a Colombian insurer, about 1.3 million of the poorest people. And the healthcare system for this group of people tended to collapse because there was so much corruption, inaccountability, an overemphasis of fighting disease and death because the professionals earned their money by fighting disease. There was a very much big waste of resources, very limited and fragmented information. There was hardly any registration about that. Very poor coordination of professionals and institutions, and finally, unnecessarily complex and administrative procedures. And he kind of, with this picture, describes the situation. He said there was distrust, nobody trusted someone else, it was kind of, and this tended to fully collapse, by which this 1.3 million people would have no health care. Alex Haddad is a very inspiring person and well known in Colombia. And he said, he asked a question to all these people, and Compensar is the insurance company. Is it possible to offer world-class healthcare services for 2.3 million people with just $500 per year, because there was no much more money, in a country going through a major crisis, because they were really in crisis? And Alex Haddad has very high aspirations. He said, I'm going to help you to reach that. And we're going to reach the OECD norms. That's the OECD is the economic corporation worldwide where they have levels to evaluate healthcare. He said, I propose that we aim these high standards of the OECD. And he said, imagine that we could do it together. And he managed to get all these people gathered with one ideal. He managed to really formulate a goal where this whole group wanted to aim for. And of course they worked it out in practical, the information. I'm not going to show all that to you, but they organized home care, they organized new information data center, they did research. Anyway, what if we decided to align our interests to create health and well-being together? So not fighting disease, but health and well-being together. And they decided to do it. So they made a trust-based integrated network with 36 care providers, one single payer, which was Compensar, with 430 euros per year for these 1.3 million people, and one common purpose, health and well-being at a very high level. And he said, we had him at a conference of us, he did teach a lot to students, and some students said, because they asked them what is necessary to succeed this, and the students had decided, you work, we call what you describe the fuck test. I'm sorry for that in these holy halls to call it, but this is the key factors for realizing is that there needs to be fear. Fear that something really goes wrong if we don't do it. So there needs to be an urgency. So the fear and the urgency go together. It needs to be not just nice, but there needs urgency. There needs to be cash, so that was wonderful with this one insurance company who really wanted to pay, and you need knowledge. You really need to know how to do it. And Alex had a team with people who had a lot of knowledge, and they did succeed. And this is now how it is. You see these big lines with the costs per unit for positive self-reported health. The USA, the United Kingdom is the Netherlands, is still also the United Kingdom and Canada. And at the left-hand side, you see what it costs them. And they reach this OECD level. They are accepted by the OECD as first-class healthcare, aiming at health, really healthcare, aiming at self-management, and it's possible. And that is why I like to include this. He wrote a book, Trusted Networks. You hope to find exactly how they did it, but unfortunately he doesn't describe it very much. But at the moment we're working on it in the Netherlands to really operationalize this Trusted Networks, really more practical, and combine it with positive health. And this is what he says, it's the ability to adapt and self-manage on a person or community level. So this is how it develops. Thank you for your attention. I was quick.